Hello, hello, hello. Happy match day, everybody. It's a big, big, big day for many folks who have applied for the residency match in the United States. Um, and of course, in classic CP Solver style, we made the horrible mistake of scheduling VMR at exactly the moment that folks get their notification. We actually also did that for the Monday version of the match in classic CP Solvers fashion. And more importantly, in classic CP Solvers fashion, we have not learned from our mistake and do that every single year over and over and over again. Um, so, yeah, the prognosis is poor in this domain. Um, I, uh, yeah, I think that today is a mix of emotions for many people, either absolutely fantastic news, neutral news, or disappointing news. Um, but whatever news you're getting, I imagine that the end outcome after many, many, many uh, uh, rounds around the sun will be a good one. Whether you're disappointed about not matching and working through that, whether you're disappointed with where you're matching and working through that, or you're elated with where you're matching, and then reality hits when you actually go to the place and realize that it actually wasn't as amazing as you thought it was going to be, and all sorts of hurdles that life will constantly throw at you. But either way, I hope you celebrate yet another day around the sun, and yet another day on Friday, RLR VMR. But again, the theme of disappointment is the disappointment is unfortunately Prof. Rez is ill and there will be no RLR. It's just me. Haha. But no, I think we're gonna make up for that in two ways. The first, of course, is our esteemed case presenter. I've given him enough formality in the huddle beforehand, and now I'd like to be a little informal and welcome my dear friend and person who probably has ice cream in his beard but is hiding it well. Dr. Jas Bajwa. Hello.
Hey Robbie, I cleaned up the beard with ice cream before this VMR. So you know what's funny? That has happened before. So
Well, believe me, I think the pretest probability of that with with everything we know about you is through the roof. How have you been?
yeah, no, life's been busy since January. I felt like I haven't had a week off for both professional and personal things. But I think one thing that really rejuvenates me is learning from cases I see at the hospital and then get a chance to present them to VMR and learn together. So I'm very excited for today's case.
Oh, so am I. I'm excited. Whenever you present, I'm always bamboozled every single time. I do have a personal favorite though. I think whenever you sneak a heavy metal toxicity into a case, it's always a special treat. So that one is especially uh, pronounced in my mind. What we will do to make up for the absence of Prof. Res, um, which is the only thing we can do to make up for the absence, is to unite the other 37 people's brains here. And so we'll do breakout rooms at least once and hopefully twice, and the goal will be to get all of your thoughts. I will encourage those of you who are part of the CP Solvers Academy, when you go to breakout rooms, please, please, please try to identify somebody who isn't part of the academy whose thoughts you want to amplify. So after we return from the breakout rooms, I'll ask our CP Solvers team members to identify somebody who's not part of the team whose thoughts um, they are willing to share publicly. So please, 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 if you are able to do that, it would be great. I'll remind you this before we go into the breakout room. And if you forget, no worries at all. I can talk endlessly as I'm doing now. Um, Jess, let's jump in.
Let's do it. I don't know. I've done this a handful of times now,
Yeah.
and I'm part of the academy. I still get nervous, and I see the all-star lineup that's here with us today. So
Yeah.
um, it still makes me nervous. But hopefully this is a good case to for everyone to learn from. Just for time's sake and everything, Robbie, there's a total of six
Oh,
aliquots.
okay. Ready.
And then the sixth aliquot will reveal the final diagnosis. So there's five aliquots to work with. And then I do have teaching points at the end.
Amazing. Amazing. By the way, for those of you paying attention, that's Jass's way of telling me not to talk too much per aliquot. so much, my friend. I appreciate it.
No, that's not at all what I was saying. But the other thing, some of these aliquots are going to be thick. The other ones are going to be not too bad. So
Amazing.
let's get started. So I did send the case ahead of time to Parisa, so hopefully that helps with scribing. But Parisa, if you feel like I'm going too fast, please let me know, and I will definitely um,
Ooh.
slow it down. All right. So aliquot number one. This is a 49-year-old male with past medical history of a myocardial infarction in 2013. Status post PCI to the right coronary artery in the left circumflex, who presented to urgent care in November for the evaluation of flu-like symptoms. So he said he was basically feeling perfectly fine about 8 days ago, and then all of a sudden developed like flu-like symptoms that he described as a cough, nasal congestion, post-nasal drip, and a sore throat. He also had 3 non-bloody bowel movements per day, which he described as liquidies, and that's unusual for him because he typically goes once every other day. He used supportive measures at home, which was over-the-counter medications, soup, bed rest, stuff like that. Did not feel better. In fact, starting to get a little bit worse. So he came into the urgent care for further testing. They tested for influenza, COVID, RSV, all of those which were negative. However, during their urgent care, they noticed that his basic labs were concerning and sent him to the hospital. The labs that were concerning was a new AKI with a serum creatinine of 2.7, baseline roughly of 1.1. BUN was 55. And the only electrolyte abnormality he had was hyponatremia at 131. He also had a pretty significant thrombocytopenia at 33 and a significant anemia at hemoglobin of 6.6, hematocrit of 18. And he did have a mildly elevated lactic acid at 2.5. And that is the end of aliquot 1.
Oh my God, Jazz, this is really, really intriguing. And I will say the most intriguing dimension is to reflect on the disconnect between what I think I would have done for this person and what has happened. And first of all, kudos to the folks taking care of this patient to recognize its relative uniqueness, which may not be captured in the HPI. If you ask yourself, how many people across the world get basic labs for cough, nasal congestion, and a little bit of diarrhea, and the vast majority of patients don't get the blood work. And so I'm intrigued, what about this scenario prompted the treating team to investigate further? Because clearly it was the right move. I think if we approach the URI symptoms and the diarrhea, the first thing to recognize is how they're linked, and they're very commonly linked by the notion that a lot of upper respiratory tract infections actually have gastrointestinal involvement. We talk about it most famously with Legionella causing diarrhea, but 25% of patients with respiratory infections have some form of diarrhea. In fact, some people with respiratory infections present with a diarrhea predominant syndrome with very subtle respiratory manifestations. So, if you're studying diarrhea and respiratory symptoms, the most common scenario is the diarrhea as a consequence of a respiratory infection in a paraneoplastic way. We don't really know what happens, but there's some sense that a cytokine-like process triggers these bowel-based abnormalities. So in most circumstances where you have respiratory symptoms and bowel symptoms, the specificity of the syndrome is located in the respiratory tract and the consequence is located in the GI tract. So here, Jas, we'll have to reflect on future aliquots about the gap between URI symptoms and a little bit of diarrhea, and what prompted this laboratory testing. Why is it important to reflect on that gap and not dismiss it? Here's why. The validity of these labs and where they live has to be either attached to the syndrome as part of it evolving, or because there is a gap between symptoms and labs, it prompts tremendous scrutiny over where those laboratory abnormalities exist. Meaning, we know his URI symptoms and his diarrhea is acute. What we don't know is the time course for these laboratory abnormalities. It would be a diagnostic error to assume the time course of the labs is the same as the time course of the symptoms because of the marked disconnect between the subtlety of the symptoms and the severity of the labs. And in fact, the relatively minimal symptoms suggests the notion that these laboratory data is at least subacute. Why? The anemia. It's hard to tolerate a hemoglobin of 6.6 that develops as acutely as 3 days of URI symptoms. So, what is the next step in evaluation of this patient? Is to really try to get data to understand the time course of these laboratory abnormalities. But how do we understand them individually in more detail? Let's start with the AKI. The practical approach to AKI recognizes that the pretest probability is all pre-renal dehydration or post-renal obstruction. Close scrutiny on the urinalysis helps us pick up glomerular diseases, and it's really, really important in patients with a surprising AKI to think about the 5 Ps of peeing. The 5 Ps of peeing. What are they? Pigment, getting a CK to assess for pigment nephropathy, paraprotein in a patient with anemia, thrombocytopenia, and AKI, really, really crucial. Pharmacy, drug-induced kidney injury, either pre-renal, interstitial. Pointy things, i.e. crystals. In a patient with a hematological fingerprint, the notion of tumor lysis syndrome is really, really important. And last but not least, platelets. Pigment, CK, paraprotein, SPEP, pharmacy, MEDREC, pointy things, uric acid crystals or ethylene glycol crystals, platelets. The overlap of AKI and thrombocytopenia is extensive, but the most morbid hypothesis is a thrombotic microangiopathy. When you see the combination of anemia, thrombocytopenia, and AKI, the first question is this patient in having a microangiopathic hemolytic anemia or thrombotic microangiopathy? No other question needs to be answered until you look at the smear and see whether this patient has cysticytes or not. And I'm holding my breath until we hear whether this patient has cysticytes or not. I've talked much more than 1/5 of an aliquot, Jazz, so I'll pass the mic to you for more information, and we'll go into breakout rooms, I think, next.
I was gonna say, I feel like we don't even have to get to the final diagnosis. I feel like your teaching is absolutely poetry. The part I loved the most is the fact that there's something I didn't mention, and that was the first thing that you honed on, and that is why did they get labs? So the patient was like, once the viral swabs came back negative, urgent care was like, hey, this is probably like some other type of virus. You'll feel better soon. And he said, no, it's almost been 10 days now. And
Mm,
I don't feel like myself. Can I please get blood work? So
yeah,
he advocated for himself.
amazing.
Uh, yeah,
Yeah, the 10 days of symptoms is like pushing it. Yep. Awesome.
yeah.
Okay, cool.
All right.
I'm glad I got.
So yeah, aliquot number 2. So this is a little bit of a larger one. So on admission, his chest X-ray was clear. However, he started developing like acute knee pain on the right. No history of trauma. X-ray was negative. There was no effusion on X-ray, no other fractures. Orthopedics was consulted, and they were not able to get anything on the arthrocentesis. He also, throughout his entire admission, would say occasionally his shoulder pain, his shoulder would hurt, his ankle would hurt, sometimes his wrist, but there was really no evidence of inflammatory arthropathy. And then hematology was consulted, considering his initial labs. They felt the hemolytic anemia was less likely given LDH was mildly elevated to 271 with a elevated haptoglobin. They recommended supportive management. By day number 3, he developed a new fever, 102 degrees Fahrenheit. and had hypoxia, required about 3 to 4 liters of nasal cannula of oxygen. He was started on ceftriaxone and doxy. CT chest showed minimal right, greater than left bibasilar opacities with no clear consolidation. Because the CT chest to the medical team that was taking care of him didn't really felt like it was a strong nidus for the fever, obtained a CT abdomen and pelvis, which showed hepatosplenomegaly, mild to moderate, with a mild acute sigmoid diverticulitis. Due to the latter finding, they did start flagyl. Patient continued to have intermittent fevers and then started to have encephalopathy. They got a brain MRI, which showed a possible acute to subacute right lacunar infarct. However, the MRI results were limited due to motion abnormalities. They were not able to perform a lumbar puncture due to severe thrombocytopenia. Antibiotics were then broadened to meningitis dosing, so vancomycin, ceftriaxone, and acyclovir. ID was consulted for the meningoencephalitis. However, they felt seems to be less likely, especially given it was intermittent in nature. So they're like, let's hold and see if he improves, and he actually did. So it was kind of like it was stable and kind of stopped even after the antibiotics were held. Before all of this, other than his MI in 2013, he's been relatively healthy. No travel, no outdoor hobbies, no tick bites, no bird or bat exposures, no exposure to farm animals, no unpasteurized dairy, no TB exposures. I can see Yaz just cringing right now. Patient would get routine TB testing due to working in a healthcare related facility. Patient is MSM with last sexual exposure 3 months ago with condom use. There was no skin rashes or lesions. HIV was negative. EBV, CMV, Lyme, Babesia, ehrlichiosis, RPR was negative. UA showed some RBCs, some protein, but no casts, no dysmorphic red blood cells. Given the progressive dyspnea and peripheral edema that started to develop, an echo was obtained and a prelim read was concerning for tamponade, and was transferred to our hospital. However, when arrived, the cardiologist reviewed the echo and then also performed his own and said it actually is a very large pericardial effusion without tamponade physiology. However, his EF was 25%, with his prior EF 1 year ago being 45%. That is the end of eloquent number 2.
Oh my gosh, I think it goes to show you how complicated real life medicine is because in many ways, this patient's part really advanced in his journey, and yet this is the first time that the receiving hospital is meeting him, and understanding the nature of his syndrome becomes really complicated as it evolves over time itself, and as interventions are sprinkled in, and the interventions that are sprinkled in is broad spectrum antibiotics for pneumonia, for meningitis. And as the patient evolves in a dynamic manner to include brain issues that then recede, it becomes really hard to know like what the core problem is. And I think the biggest piece of advice that I would have for anybody is to continue to be open to things evolving. So we talked initially a lot about the kidneys, but now that the center of this disease is more diffuse and the weight of this disease is heavier and heavier and heavier, it becomes more and more plausible that the kidney is an innocent bystander in a systemic disease process. And so, what happened to his creatinine is key, and I think also what happened to his anemia and thrombocytopenia is key. Um, but we learn of the interesting development of a potential vascular imprint with a stroke on his MRI and a potential cardiac imprint with a low EF and tamponade, and an even more prominent fingerprint than initially realized, which is his hepatosplenomegaly. We also learned that he is febrile. And so trying to distill the most diagnostically useful things from the things that tend to be consequences is really difficult. A febrile a fever and hepatosplenomegaly tends to be a fairly diagnostically specific and often a reliably core variable in pursuit of the diagnosis. That's in contrast to the presentation of a stroke, which may be a consequence of the hypercoagulability of an inflammatory process. It's also in contrast to a low EF or even maybe a pericardial effusion, as they have tendency to develop in volume overload states and have less specificity. So I think the hardest job we have now is to ask ourselves, what are we going to use as our core discussion, and what are going to be the modifiers that help us adjust this case? And I think a febrile presentation with hepatosplenomegaly is at the fundamental root of this case. And in the realm of infections that tend to cause hepatosplenomegaly, there's really three classes of them. They're the mononucleosis infections, HIV, EBV, and CMV, which have been assessed here with good but not perfect tests. The other category is tick-borne diseases, which again have been tested with good but not perfect tests. And then lastly, the granulomatous infections. These granulomatous infections include TB and histoplasmosis as the most famous ones, and the analysis of the probability of these conditions is related to the patient's exposure and where they live. Of these three, mononucleosis, tick-borne infections, and granulomatous infections, the granulomatous infections are the ones most likely to have a respiratory involvement, with EBV, like mononucleosis and tick-borne diseases, relatively sparing the lungs. However, we haven't really concluded that the lung involvement is disease specific. It may simply be a consequence of the inflammatory state that may be bordering on the spectrum of an HLH-like presentation that is causing consequence in the lung and not the primary culprit. There are many autoimmune diseases that affect the spleen in particular, but none of them are important enough to consider initially first up when the patient is this critically ill. The only exception to that is lupus, because that notoriously will have cytopenias and progress to an HLH-like presentation, and an ANA is an easy test to help reinforce or exclude that condition. Malignancies are really important to entertain here, usually of the liquid type, lymphoma or Castleman's disease. The thing that argues against them is a relative acuity of the disease process. But again, if it's complicated by a hyperinflammatory state like HLH, they can certainly take off. So what are the priorities in this patient? I think there's a low threshold for empiric doxycycline in a patient who, even though they don't have prominent tick-borne exposure, a febrile hepatosplenomegaly patient probably might benefit from doxy, and if they turn around very quickly, there's your answer. I think close scrutiny for any epidemiological exposures, especially to histoplasmosis, I would say, is really, really important. And then in terms of next diagnostic steps, I think that if the cytopenias are very prominent and remain so, a bone marrow biopsy tends to be informative in these patients. I also think the pericardial effusion might be really, really interesting here, given the concern for malignancy, and if it's of a sizable value, tapping it and assessing whether it's got pus, AFB organisms, or tumor cells can be really, really helpful. Biggest piece of advice, this aliquot is teaching you, I think, about how to separate core data from non-specific consequence. The most common non-specific consequences are ATN in the kidney, encephalopathy from multi-organ failure, septic cardiomyopathy. The core of this case, I believe, is its hematological fingerprint of fever, cytopenias, and hepatosplenomegaly, and that will have to explain. It remains to be seen whether things we've initially labeled as consequences become more and more fundamental. Given the size of the pericardial effusion, I think that's the one possible thing that is often as a consequence that may be a core variable in this case. All right, Dr. Bajwa, you're stretching me here, my friend. You're stretching me.
No, not at all. I promise you this is not a West Nile virus case or a blasto
All
case.
right.
No, this is great thoughts. So some more data. So aliquot number three. He was actually taken into the OR shortly after he arrived at our hospital for a pericardial window, and they drained about 550 to 600 cc's of serous fluid. Um, his labs here basically were similar to the other ones. His white count was about 5.1, low lymphocytes, mostly neutrophils, and everything else was stable. His H&H is stabilized around 8 after getting blood transfusions, and his platelets was like hovering between 30 to 50. And the pericardium was sent off for pathology and was consistent with acute and chronic inflammation, which was non-specific. The fluid was negative for malignancies, so cytology was negative, and all cultures that were taken off the fluid was no growth to date. Additional labs for you all, ferritin was high at 1,154, D-dimer was greater than 7,000, fibrinogen was elevated at 889. PTT was elevated at 60, PT-INR was elevated at 16 and 1.4 respectively. Peripheral smear was reviewed by the pathology team and revealed abnormal mononuclear cells, approximately 4% favoring blasts, abnormally segmented neutrophils, giant hypogranular platelets, and nucleated red blood cells. Vitamin B12 and methylmalonic acid was normal. Folate was normal. Lipid panel was normal. ANA was positive to 1 to 160, speckled pattern. ANCA was negative. Anticardiolipin was negative. Anti-SSA, SSB was negative. Anti-double-stranded DNA was negative. C3, C4 was within normal limits. G6PD was sent off as well. That was normal. Rheumatoid factor and anti-CCP was sent. That was normal. ESR was elevated at 61. CRP was elevated at 32. And that's the end of aliquot number three.
Oh my gosh, this is so interesting. And I think the biggest thing that's emerged is this notion that the pericardial fluid, thankfully, is not overtly infected with purulent material. And I think given the acuity of this presentation, that was certainly possible. Um, can you just remind me, I missed this because I actually snuck in a look at my phone to see the wonderful news coming our way. The hemoglobin, was that still low? Guys, I heard the white count's kind of not super low. He's still prominently anemic. Is that right? Gotcha.
Yeah, I
Okay.
mean, like it stabilized hemoglobin of the eights after blood
Yeah,
transfusions, though.
I see.
He needed multiple blood transfusions.
Nice. Awesome. Yeah, thank you for clarifying that. I think the biggest signal that's emerged is the idea that the bone marrow is involved in this disease process. And I think that whenever you have hepatosplenomegaly and cytopenias, the probability of that bone marrow involvement is very high. And the question is, what is the nature of that bone marrow involvement as we can see? And I think it's interesting to reflect on that. We see abnormal mononuclear cells with a hint that they may be blasts. So when blasts are involved in cases, we usually invoke the idea of a leukemia. And patients with leukemic presentations, I mean, at the end of the day, if we step back and say, could this be acute leukemia? The answer is absolutely yes, with the patient having cytopenias, and then maybe an infection as a consequence of that. I think the possibility of acute leukemia is a little bit less likely in a patient who has HLH-like presentation, with lymphoma and Castleman's being much more common triggers um, of that. At the end of the day, I think the practical analysis is say there are nucleated red blood cells in this person's blood, and there are blast-like cells. The probability of the marrow being involved is very high, and assessing the marrow is going to be fundamental. A reflex that's triggered that I think should be triggered in all of us is whenever you see a young person with cytopenias, coagulopathy, and a hint that there may be abnormal marrow, acute promyelocytic leukemia or APML should be a reflex for us. Cytopenia, abnormal marrow, coagulopathy. The reason that should be a reflex for us is the probability of intracranial hemorrhage goes up with every single day APML is undiagnosed and untreated. So I think we now can say that this is a young man who has problems from head to toe in a devastating manner. The specificity of all those problems as a consequence of the diagnosis is of question, but what isn't of question is the prominent hematological thread that is coursing through and possibly causing all sorts of consequences. Keeping your eye focused on the core issue is the hardest part of this, because in real life, you're also tasked with managing all those consequences. You're managing the kidney issue, you're managing the stroke, you're managing the infection, making it really hard for you to see what really is fundamental to this case. And I think what is fundamental to this case is its hematological fingerprint. The peripheral workup, the non-marrow workup for any disease that has a prominent hematological fingerprint, is all the infection stuff we talked about. And of course, as we alluded to earlier, the ANA assessment. So the morbidity of infection cannot let the sun set on all the infections we thought about. The possibility of lupus has to be entertained in a patient who has ANA positivity and a hectic HLH-like presentation. That possibility is lowered in this patient who has normal C3 and C4 and negative subserology so far. It's lowered to pretty low, um, but it has to be counterbalanced by the patient having lymphopenia, which makes you curious about the possibility of lupus. At the end of the day, we'll only be able to prominently assess for autoimmune diseases like lupus after we thoroughly excluded infections and malignancies. At this point, I think the most valuable test would be to understand what's happening in this patient's bone marrow. All right, Jess, why don't we get the next aliquot and then we'll do breakout rooms.
Sounds good. All right. So aliquot number 4. So remaining serology, which included anti-Jo, anti-SCL70, RNA polymerase 3, at this time started coming back when it was normal. I did not start seeing this patient just yet, so I just want to clarify this, but they also sent a West Nile, which was negative. IgG4 was sent. It was actually low, IgG4. It was 1.3 with the range being 2.4 to 121. But the total IgG was elevated at 2309. Kappa to lambda ratio was normal at 0.54, but both kappa and lambda were elevated. SPEP was within normal limits. There was no polyclonal or monoclonal gammopathies. A bone marrow biopsy was done, which showed hypercellular marrow with multilineage dysplasia, increased blasts, 7% of marrow cellularity. There were some ring sideroblasts that were identified. There was also a P53 mutation that was detected. Flow cytometry of the bone marrow did not show any monoclonal B cell population, no aberrant T cell population. Given his clinically, he didn't look like terrible. He was a little ill appearing, but wasn't toxic. He actually was able to wean down to 1 liter. He also wanted to kind of get out of the hospital because he had work to do and all that kind of stuff. So the team that was taking care of him at the time said, okay, let's follow up in the outpatient setting with hematology. There were plans to start him on treatment in the outpatient setting. However, patient unfortunately got readmitted in the beginning of January. So he was only home for 2 weeks. He came back to the hospital for nausea, vomiting, non-bloody diarrhea, really bad abdominal pain, and a fever of 101 degrees Fahrenheit for the last 2 days. He denies any sick contacts. A CT scan of the abdomen and pelvis showed thickening of the urinary bladder with marked inflammatory changes, suggestive of cystitis. It also showed mild proctitis. It also showed pancreatitis. Procalcitonin was elevated in addition to leukocytosis and hypotension. There was also an elevated lactate at 2.8. Patient was started on vancomycin and Zosyn for sepsis, and patient's hypertension did resolve with IV fluids, did not need any pressor support. Dating back to his prior hospitalization, trending his labs compared to his prior hospitalization a couple of weeks back, His ferritin has now been continuously been rising now. His CRP now is 294. His ESR now is 190, is 91. And an IL-2 was sent out and came back elevated at 10,000. His ferritin started to creep up to 5,400 and it peaked around 6,500. That is the end of
Wow.
aliquot number 5.
And so the next aliquot will reveal a diagnosis, is that right? Or
Sorry, I was supposed to say aliquot number 4.
Okay.
There's one more aliquot.
All right, sounds good. All right, y'all. Put your brains together, and we'll reconvene in a few minutes. Everybody. Oh gosh, welcome back, welcome back, welcome back. Sorry. I think all of us are very distracted by the CP Solvers Academy chat um, where we're learning where all our wonderful Academy members are going. I hope you had a wonderful discussion in your groups. I think Dr. Bajwa, as expected, I grossly mismanaged the conversation, and so we'll power through because we're near the hour. Instead of our pre-existing plan to hear from the crowd, I think we'll probably run over, unfortunately. So, what progress have we made? Again, Jas, by presenting us the case so authentically, with basically inundating us with data, you're giving us a real life practice of what it's like to actually see the signal from the noise. You spent quite a bit of time sharing with us what happened to this patient with all the bowel and bladder things that they were having. If we're focused on the diagnostic exercise, unfortunately, it's too complicated for my mind to do anything but ignore that data, because it's so easy to view that data as a consequence of the patient's immunosuppression and a hyperinfection from those mucosal surfaces, the GI and GU tract. It's hard to think that the diagnostic specificity of this disease is going to come from those conditions when it's so easy um, to view those places as consequences of the immunosuppression. And it's even more likely because now I think we have a fundamental problem that I think we've discovered. Before, you heard me using the term HLH-like presentation. Well, I don't think we need to use that anymore. This person has an HLH-based disease. The criteria for HLH have been met because this patient has splenomegaly, fevers, a high ferritin, a high elevated IL-2 receptor, and has end organ consequences of that. So if you can diagnose this patient with HLH, fundamentally. But diagnosing this patient with HLH is no different than diagnosing them with neutrophilia or eosinophilia. HLH is a signature of inflammation that doesn't tell you what's going on, but restricts the differential diagnosis to conditions that tend to have macrophage activation as part of their phenotype. And the syndrome of macrophage activation can be as a result of all the categories of inflammation. It can be infectious, it can be autoimmune, it can be malignant, it can even be drug induced. Gosh, you guys know it can even be mosquito sting bite induced in some unfortunate patients who have a genetic predisposition to HLH. So the question now is, how much progress can we make? And we can make a tremendous amount of progress because it's only a subset of infections, a subset of autoimmune diseases, and a subset of malignancies. Thankfully, this patient has not been bitten by mosquitoes or has any drugs on board that we have to worry about. So the question is, what kind of infections? We already talked about them. Mononucleosis-like infections, tick-borne infections, and granulomatous infections. Mononucleosis-like infections and tick-borne infections take off and do not have a recurrent presentation. The patient should not get better or worse. The same is true of granulomatous infections. It's hard to imagine that the patient has devastating TB everywhere or histo everywhere and without treatment got better enough to get discharged only to come back. Cancers, lymphoma. Could this patient have a lymphoma or its cousin Castleman's, multifocal Castleman's disease? Absolutely. The thing that dramatically reduces the probability of multicentric Castleman's disease is the absence of lymphadenopathy. Virtually every single patient described with multicentric Castleman's disease has extensive lymphadenopathy, and the lack of it here, at least that I registered, I might have been distracted, reduces the probability of that condition. Ultimately, here, we'll have to test for all the granulomatous infections. We'll have to work so hard to not miss a lymphoma, but the clue is better and worse. This is a biphasic HLH. A biphasic nature is supportive of an autoimmune condition, hinted by the ANA positivity. So let's jump into what kinds of autoimmune diseases trigger HLH. And I'm going to show you a visual. Here they are. Which one of these conditions is associated with bone marrow dysplasia? It's VEXAS syndrome. So, where are we at in real life? In real life, you have to send every single granulomatous test you can think of. You have to look really hard for malignancy and ask him to even consider bone marrow biopsying a patient. But in a middle-aged man who has biphasic HLH, autoimmune disease appears to be the most likely. When you factor in the dysplasia, you wonder, could this patient have VEXAS? That's my most concerning hypothesis now. There should have been more characteristic features of VEXAS on the initial bone marrow biopsy, but that can be easily missed. If I were taking care of this patient now, what would I advocate for? Either reassessment or reacquisition of the bone marrow. In addition to testing for histo and another round of testing for liquid malignancies. Mike, to you, my friend.
Rob, it's very impressive. This case was overwhelming for me. That's not that much of a surprise, but it was also very puzzling for a lot of the other members who were very experienced in the oncology world. And the way you pieced it together in real time, like I presented this case as authentically I could have. Like I didn't modify anything or changed anything. So, it's really impressive how quick, like, yeah. So really great thoughts. Rabih, if it's okay with you, I'm gonna combine the last two LCOTs and I'll just take you to the journey because I think you're basically there. So, I reviewed his CT images for the past couple of months, and like this shows the difference between like a experienced clinician such as Rabih versus someone like me who's still learning. I looked at his CT images for the past couple of months, and I noticed something weird, at least at the time. I was like, this guy has gotten cystitis, proctitis, pancreatitis, hepatosplenomegaly, and even myocarditis findings on imaging, which all resolved by the time that they would repeat the next CT scan or echo or whatever. And I found that weird because sure, antibiotics can help inflammation or whatever, but we all know that there's some radiological lag when it comes to infection. So that made me think of a hyperinflammatory syndrome, and I was like, this is less likely to be an infection. Certain viruses could do that, but all virus testing that he has had done so far was all negative. So, the hematologist team that I was working with was really great. We all sat together and just kind of would just talk about this patient because they spent learning this patient since November was pretty a difficult task, and the more brains together, the better. So there was oncologists were concerned for a possible AML transformation. However, what didn't fit with that was one of the oncologists said that they did see one case of AML that did lead to like these hyperinflammatory like findings on CT stuff. And but they kind of felt like let's do other things. And that's when we started talking about VEXAS. and they sent off I forget the gene, but the ubiquitin gene mutation, which actually came back negative. His white count also started to downtrend, and he's UBA1. Thanks, Ravi. So basically, when that was ruled out, we kind of wanted to repeat a bone marrow biopsy. So exactly what Ravi said in the earlier aliquot. And the bone marrow biopsy did not show any evidence of HLH, and the patient continued to have abdominal pain with a repeat CT scan again, which showed basically some resolving organs and then some new organs or new areas of organs that were inflamed. So then the decision was made to start anakinra and steroids. But the oncologist I was talking to, he goes, hold on, let me just repeat a bone marrow biopsy one more time before we start anakinra and steroids. And this time they did a different location, and that one showed increased blast from 8 to 10% with increased histiocytes that showed hemophagocytosis. And the patient was diagnosed with HLH. And as soon as the anakinra and steroids were started, the inflammatory markers in IL-2 started downtrending very significantly. So then the question became, and I'll dive right into my teaching points. The question came about like what led to this HLH. So that was the main thing. So repeat scans did not show any lymphadenopathy. We took biopsies of the colon that did not show any lymphocytes. We repeated a flow. We repeated, there was no lymph nodes that we could safely biopsy. Patients' febrile episodes, everything clinically started improving when we started treating the HLH. He just had a PET scan a month ago, so this was after his discharge. No basically concerning signs for like increased uptake of lymph node activity in the lymph nodes. Then they also sent off a genetic panel for primary HLH, all came back negative. So then it's like, okay, well, hold on, then what's the trigger? So that goes into my teaching points. So this patient was actually diagnosed with myoplastic dysplastic syndrome. And this is all learning that I got from this case, was there's two forms of MDS. One is indolent, low grade. Sometimes you can read it as low risk, versus aggressive, high grade. And it matters because life expectancy of patients with low grade MDS can range between 6 to 12 years, whereas high grade, even without converting to AML, is 9 months to 3 years. If they do convert to AML, unfortunately, it's like 9 months or even less sometimes. So this patient was actually diagnosed with MDS, HLH secondary from MDS. And it's specifically high-grade MDS. And then how can one tell between AML versus high-grade MDS? If the blast, so this is an oversimplification. I want to clarify that. But if blasts are greater than 20%, it's AML. If it's less than 20%, it's likely to be high-grade MDS. However, there is a variant of AML with recurrent genetic abnormalities that only needs greater than 10% blasts. The odds of MDS converting to AML is also a very complex matter, and it can range between 25 to 50%. And then basically, MDS MPN can present with splenomegaly, but it's very rare with pure MDS. So in retrospect, we thought maybe this was a perhaps overcall by radiology versus this was the HLH that was manifesting. Both the oncologist agreed and ID agreed that the time course was very atypical for HLH, because my illness script for HLH, this is my fourth HLH case that I've seen. The other three that I've seen were EBV, lymphoma, and histo. And all three of those patients were toxic appearing in the ICU. And this patient, yeah, he was ill appearing. He was below his baseline, but never needed that ICU level of care. So that was another atypical variant that for me was new and did not completely fit. With regards to the TP53 gene mutation, that was something that was new for me too, because I've only associated that with solid tumors. But 5 to 10% of myelodysplastic syndromes can have, or AML can have TP53 gene mutation. And these can either be monoallelic or biallelic. In 70 to 75% of cases, they're biallelic, just like this patient. And they're unfortunately associated with resistant to most treatment, unfortunately. Bone marrow transplant is usually their best chance. However, the risk of relapse post-transplant is very high. So very quickly, HLH could be primary or secondary / acquired, like secondary to infection, malignancy, rheumatological disease, post-allogenic hematopoietic stem cell transplantation, and then drugs hypersensitivity. It's rare, but there are reports of myelodysplastic syndrome leading to HLH. Malignancies are seen in 40% of case, or 45% of HLH adult cases, where viruses like EBV are more common in kids and adolescents. Yeah, lymphoma, you guys already mentioned it, was by far the most common cause of this. So that's my end of my teaching points and case. I thought this was a pretty interesting case, and I hope if this wasn't new things for you, at least a good review.
Oh my gosh, if it's not new for you, then I think you should retire because you've seen all of medicine. I've never heard of this or seen this before, Jess. My only overlap of dysplasia and HLH was Vexus, and I didn't realize that aggressive versions of MDS can trigger HLH. This is completely new learning for me, and I'm really, really appreciative of it. I'm also really appreciative of the idea of how dense the board is. I think Shayma's fingers are probably very, very tired from outstanding scribings from the VMR legend. And it's funny actually because Shayma had given me practice to think about HLH 2 days ago when she shared with me a case of disseminated TB that had the HLH fingerprint of a very elevated IL-2 receptor as you presented today. So I had just reviewed those schemas like within 24 hours thanks to Shayma. But I think it goes to show you how hard it is to figure out signal from noise. And all the noise um, that suffered as a consequence of the HLH, the ARDS, the brain, the GI, like all of that. And ultimately, we're saying that one stem cell mutation in the bone marrow with a TP53 mutation unleashed hyperinflammation. One population of cells to think about how complex this patient is from head to toe, and yet a strategic lesion in the bone marrow triggers consequences everywhere, and really authentically practicing with everybody here. What signal was noise was an honor and a privilege, and especially when we get to do that with learning something completely new, which is MDS being a trigger for HLH. Never heard about it. We'll read a lot about it thanks to you. I would just emphasize what you said, which is HLH is not a diagnosis. It's an inflammatory fingerprint. Just like eosinophilia is an inflammatory fingerprint that changes the differential diagnosis of inflammation. It's skewed inflammation or funky inflammation, as we like to call it. And so I'm glad to be able to add MDS into my list of infections that do this. Anyway, a real treat. I'm really sorry. I'm actually already 5 minutes late for rounding with my team. So, Jas, I made you the host. Are you able to stick around for Anmol's teaching points? Awesome. Well, Anmol, thank you so much for your teaching points in advance. I really look forward to listening to them on YouTube later. Happy match day, everybody, and look forward to seeing you next time.
Amazing, amazing case. Thank you so much, Dr. Jess. So I'll just rush through my teaching points. Basically, we just had respiratory and GI symptoms together. So we thought that respiratory infections and diarrhea, they're interlinked and they can be mostly seen together because of a cytokine-like process which is responsible for the bowel abnormalities, where actually the problem lies in the respiratory tract and GI symptoms are a consequence. And the first aliquot but we saw that the labs were really severity that was there, but the symptoms were minimal, which made us think that the lab changes were subacute, because a sudden drop of HB will make the patient really, really sick. So we just think that these lab changes are subacute. And then we think about the AKI, we think about 5Ps, which can be pigment nephropathy, paraprotein, pharmacy, that is drug induced, pointy, that refers to crystals, that means uric acid or ethylene glycol, and platelets. So these all are the 5Ps for AKI. And we saw that there were so many problems in this case, so many symptoms. So to find out the core problem and so many symptoms is important, because other could be just the manifestation of the body's reaction. For example, the encephalopathy we saw, it could be as a result of multisystem disease. And so we just thought that we need to get a bone marrow biopsy given the pancytopenia we were seeing, and a pericardial tap to see if it was infected or what was there inside. And then we saw that the patient, the disease was not limited to respiratory or GI tract. It had a really large systemic imprint. And stroke history makes us think of a vascular cause. And then we saw that the patient was febrile, had cytopenias with hepatosplenomegaly, which we thought that was the core problem in this patient. And if we say that this is the core problem, what are the three differentials? Mononucleosis, that is EBV-CMV, which was ruled out, tick-borne disease, rickettsia, granulomatous infections, and respiratory tract is more involved in granulomatous infection more than tick-borne or mononucleosis. And then when we saw that the patient had cytopenia, abnormal marrow, and coagulopathy, we think of APML, which can also lead to intracerebral hemorrhage. And then we realized gradually that this patient indeed had HLH. So we just cannot say completely that the patient diagnosis is HLH, because diagnosing a patient with HLH is like diagnosing a patient with neutrophilia. It just basically HLH just tells us that that macrophage activating system is a part of the phenotype of the actual disease of the patient. And we saw that this patient has biphasic HLH, which signaled towards an autoimmune disease. And given the bone marrow was dysplastic, we thought that it could be Vexus syndrome. So it would be like helpful to send UBA1 gene mutation testing in this patient to check if the patient is indeed having Vexus syndrome. And that came out to be negative. So our differentials, seeing the recurrent nature of the disease, were cancer, lymphoma, multifocal Castleman's disease, which went down to the list because of the absence of lymphadenopathy. And ultimately, the patient was diagnosed as a case of myelodysplastic syndrome, and the HLH was considered secondary to that. And MDS is basically of two forms, that is indolent, low grade, or aggressive, high grade. And this HLH was secondary to MDS, which actually HLH can be primary or secondary, that is acquired. So I learned a lot from the case, and I think I need to look a lot in my notes today. Thank you so much for this.
Amazing summary there, Anmolpreet. I can't believe you're able to capture all of that with such a complicated case. With that, thank you everyone for joining, and I hope you all have a great Friday.